Now the next speaker is Dr. Kirti JAISINGH. She'll be talking on navigating the diagnostic and therapeutic challenges and management of ocular budgets.
Good afternoon, everyone. At the outset, I would like to thank the scientific committee for giving me the opportunity to present my work here. So, what is Behçet's disease? So what is Behçet's? It's a generalized systemic variable vessel vasculitis, and we all know that it has diverse manifestations ranging from head to toe and often recognized as a triad of recurrent orogenital ulcers with uveitis. It is a frequent disease but highly underdiagnosed and underreported in Asian population. Out of the various criteria that are used for the diagnosis of Behçet's disease, we use the international criteria for Behçet's disease, where we give 2 points each to ocular lesions, genital ulcers, oral ulcers, and 1 point each to skin lesions, neurological manifestation, vascular, and if positive pathology test was there. So we conducted a retrospective study and analyzed the demographic and clinical profile of these patients with ocular Behçet's in presenting from the Western India, and analyzed the treatment approaches used and their outcomes. So we collected the data from January 22 to May 24 and included not only the ICBD criteria but also the patients who were HLA B5 or B51 positive, and the patients who presented to the uveitis clinic with the ocular symptoms or referred from the other departments with systemic features, and who had completed a minimum follow-up of 6 months. So out of total patients, 97, we found Behçet's in 12 patients, and the patients who completed a 6-month follow-up were 10 patients with 18 eyes involved. So what we found was the mean age of these participants was 31 years, and males outnumbered the females by a ratio of 7:3. Bilateral presentation was seen in 80% of the cases. 80% of our patients had oral ulcers, 20% had genital ulcers, and 1 patient came with CNS involvement. Majority of the patients presented with diminution of vision. Now, most of the patients had pan-uveitis. It was present in 61% of the cases, followed by posterior uveitis, followed by anterior and intermediate uveitis. Mostly the anterior segment finding included the cells, and in few cases it included hypopyon and keratic precipitates, posterior synechia. The posterior segment finding mainly included active or healed vasculitis, retinitis, vitritis. In few cases, ERM and disc pallor was also seen. So on OCT, we found that macular edema was seen in 2 cases, and epiretinal membrane and loss of ellipsoid zone were present in 3 and 2 cases respectively. The FA findings corroborated with the posterior segment findings clinically. It revealed diffuse ferning pattern of perivascular leakage in 7 eyes. Staining of the vessel wall was seen in 7 cases. CNP areas were found in 9, and neovascularization was seen in 5 cases, and 4 had already come with vitreous hemorrhage. So the major complications that we saw in our patients were cataract and glaucoma in 5 and 6 cases. And the mode of treatment that we employed were steroids plus immunosuppressants at the very first visit. Most of these patients received azathioprine. In 2 cases, we had to go for cyclosporin, and adalimumab was started in 1 patient. And all the patients undergoing treatment showed improvement in the visual acuity. However, 20% patients had an end-stage disease. So when we compared our study from the previously done studies from North India and South India, what we found was a higher presenting age. Maybe they had come late at our center, but it does corroborate with the other studies also. The systemic involvement revealed lesser amount of genital ulcers and no skin involvement in our patients. Panuveitis was the most common presentation. Common ocular findings also revealed vasculitis in around 90% of the patients. Our treatment differed from the other studies with the immunosuppression started in almost all of these patients. And so we found a lesser number of complications in our study. And we found that there is a good amount of improvement with early induction of immunosuppression. So if we compare it, it was a retrospective design, and the duration was short, a 2-year duration, as compared to 5 to 15-year data from North India and South India. But we found a higher prevalence of Behçet's among uveitis as compared to 1%, 1 to 1.5% from the other areas. and lesser genital ulcers and skin involvement in this region. So my take-home message is that Behçet's is not an uncommon disease. It just needs a high clinical suspicion, and early use of immunosuppression or biologics offers sustained control and better long-term outcomes to avoid long-term complications and early recurrence. Thank you.
So within your cases, did you find any glaucoma, secondary glaucoma?
Yes, yes.
Yes. What anti-glaucoma medications you used?
Sir, we used mainly.
Because it is not mentioned here.
Yes, we mainly used a combination of timolol and mainly used timolol. It mainly subsided with timolol only, and in some cases we had to use a combination. Most of the times, IOTM and
carbonic anhydrase inhibitor, like that.
Carbonic anhydrase, not carbonic anhydrase inhibitors, alpha blockers and alpha agonists and beta blockers were used.
Okay.
Any comments, sir?
I just want to tell you that it's not necessary to do that HLA B51 or B5.
Yes.
Nowadays, that they tell that it may be negative in Behçet's disease, or
Yes.
it can be positive in other diseases also. So they have
It's
taken
not
up
specific.
that HLA B51 and for the recent classifications of the sun. And the second thing is that aphthous ulcer, either history of aphthous ulcer or recurrent aphthous ulcer must be present in a case of Behçet's disease to name it as a Behçet's.
Yes, so we referred all our patients for a confirmation to the rheumatologist. All the patients were referred. HLA-B5 was done as an additional entity in all these patients. But yes, we diagnosed our patients according to the ICBD criteria.
Thank you, Dr. Kirti.